can't tell you what a privilege and really an honor it is for me to be here. When I had this opportunity and Jason provided me the syllabus of the backbones of this organization, I was really overwhelmed by it. You know, I'm blessed to have Jim Withers as a colleague who I've been taking care of his patients for the last 21 years. But you guys really have an unbelievable networking group, and my accolades, my hats are off to the Santa Barbara community, because you really are a role model, and hopefully you'll teach me a lot more than I teach you. I've traveled the world, I've lectured the world, and I was looking forward to this actually more than most of the lectures that I've given. And so what we're going to talk about today, as I teach my residents, is that we don't want to do a lot of memorizing, but we want to think in principle. Because principles will stay with us forever. And you live in detail, but the things that you want to learn are the basic approaches to the problems that we see. So for this audience, somewhat of a show and tell. But at the end of the day, I think there'll be a message that I want to bring to all of you, and that what Jason is showing you by giving back is the world's greatest reward. So without further ado, by the way, let's make this very informal. Interrupt me if you'd like, just don't throw things. So, what is a wound? The American Heritage Dictionary describes it as an injury, one in which skin or other external organ surfaces are torn, pierced, or otherwise broken. So it's fairly simple. So I think any time you talk about medicine, you have to know its history, because Jason, how many times we had to go back to that history? You know, when we get into these primitive environments, you got to MacGyver it, right? So you got to figure out where you come from to figure out where you're going to. So wounds have been documented since 2,000 years BC, or 200 years BC. And it was Hippocrates that really documented in archaeological drawings that gladiator wounds should be closed. And he talked about a laudable pus, which is today what we see in an emergency room situation that usually will put a patient in dire straits. But then we go a series of almost 2,000 years where we were lost, basically. The prehistoric literature that came about was lost in the medieval days. And then all of a sudden, it took until the 1800s, where Graham Lister said, if we clean up the environment, we could perhaps reduce the incidence of infections. And then, about 40 years into that, they decided when wounds were created, it was just taught to leave them open. But if you had a window to close them in a clean environment, the incidence of infection was considerably less. We sterilized instruments at the end of the 1800s, and then it wasn't wasn't a time after that the use of ether in anesthesia became available to us, and it allowed us to work much slower, lessen the blood loss, and accomplish great things in the surgical theater that we couldn't do without it. And then the interesting story is that Halsted, who's the father of American surgery, came up with the idea of surgical gloves, but it wasn't his idea, actually. It was his mistress, which was his surgical nurse. And at the time, for antisepsis, they used to put carbolic acid on the wounds, and that would not only stop the bleeding, but the acid itself would kill everything around the environment, including the tissues around it. And she had to put the carbolic acid on the wounds. So she said, hey, Dr. Halsted, it's either my hands or gloves. And that's basically the story of how surgical gloves came about. The antibiotic era allowed us to keep people alive longer because we were able to help the body fight the host infection. And then without question, it's the sophistication today of our ability to monitor patients, to keep patients asleep for 36 hours, to put people in barbiturate comas for weeks if we have to keep brain swelling down, to do all the things that we have to do that we can make amazing advances in surgery. So, who's at risk? And the street population will come into this as we get started. But it's the aged, the malnourished, the immunosuppressed, those that are taking either drugs for cancer or disease, heavily contaminated wounds, compromised blood supply, and the metabolic conditions, which are really what the homeless population seems to have neglected, and that's the management of diabetes, uremia, cardiac disease, pulmonary disease. And when you compound these things together, and then you don't have access to medical care, your chances of surviving these these events are quite are against you. So in principle, when you're wounded, the body has to be given an opportunity to heal itself. It's not the magic antibiotic or the bacitracin ointment that, in my opinion, is what you don't put on wounds, but it's the ability to give the host the best chance at healing. And you do that by all the adjunctive supports that we were talking, or that we alluded to. And that is, optimize the nutrition. Give the appropriate antibiotics when indicated. Take surgical control of the wound. Adequate debridements, and then the appropriate surgical intervention when the timing allows for it. This is where the street person is really at a disadvantage. So the methods of destruction are many. It could be bacterial, it could be toxin related directly, it could be viral, it could be fungus, and you put all these together in a compromised host, and it becomes very difficult to try to overcome these problems. A simple pimple, as I'm going to show you, can turn into a life-threatening event. So what we try to do is we try to optimize the wound environment. So all the things that I talked about, we try to reverse, and then by doing so, we want to reduce the bacterial load, we want to decrease the level of tissue necrosis, and then what we want to do, it's all about the blood supply. And so it's like you're watering the garden, it's putting fuel in your gas tank, it's bringing blood to the environment so that all the things that go with the special cytokines of healing are available. So, if you want to talk about, and I guess many of you in this audience are interested in going into medicine, and in my opinion, the doctor-patient relationship starts out like a date. It's no different. That consultation starts out as a hello. And at that point, there's a chemistry that's established. It's a bond. If you guys and girls go out on your first date, and within the first 15 minutes, you know it's not going to be right, it's going to be a very long night. The doctor-patient relationship is the same. And so through that, you want to develop a chemistry of personalities. You want to develop trust. The patients have to trust their doctor. And then through that, there's a mutual understanding. You have to understand them, they have to understand you, and together, they have to comprehend the plan. They have to figure out that what you're trying to do is going to make them better tomorrow. And they've got to come back to see you, and they've got to follow up with you. And so these are really the simple ingredients of a successful doctor-patient relationship. So, what's lacking in the street medicine population? Number one, it's the chemistry. Number two, the trust, which is a very big factor. Many of these people have been through difficult times their entire lives, so they've been growing up not trusting, so it's very hard for them to basically open their hearts to you. The understanding component goes without saying. The compliance is a big problem because they can't get to you, and in many situations they've been turned away, as Jason and I were talking about earlier. And the follow-up, which is again very important. You've got to try to start what you finish. Because you don't grow a garden overnight, you don't heal somebody overnight, and the environments change all the time. So, we're wound detectives on the streets and in our clinics. So the first question is, we ask why. But why, as we found out earlier, do we drive on parkways and park in driveways? Because that's what I took it from Jason today, and I'll take that back to Pittsburgh. We have to recognize a wound is just not something you put a Band-Aid on and hope that it goes away. You have to recognize what are the mitigating factors in that person that are not making this happen. If I cut every one of you in this room, which I promise I won't, but you should all heal uneventfully. And if you don't, there's got to be a reason. Again, we talked about surgical control of the environment, medical management of the host, which is that's critical. Somebody that's in florid congestive heart failure, somebody who has an blood oxygen level of 30, and there's no way, because they smoke 4 packs a day and they've got terrible emphysema, and they can't lie down because they can't breathe, they're going to have a real tough time. A diabetic with a sugar of 400 is going to have a real tough time. Somebody with a nutritional level that should be 4 and that's 1, they're going to have a real tough time. So these are the things that we try to recognize. So, Jim, got you in action, brother. The approaches to the problem, and again, this is something that, and I'm very proud again to be a part of, at least associated with a guy like Jim Withers, because there are some people that do this because they're supposed to. There's others that do this because they want to. He does this because his heart drives to do that. There's nobody, in my opinion, that is more dedicated to the human spirit than Jim Withers, and so I really, again, wholeheartedly am very honored to be on this podium with him. But you've got to establish a caring trust. And you know what? Everybody wants to be respected. You walk into a place and you diss the guy that comes in and says, you stink or you smell or go, wash, whatever. And right away, they've been belittled their entire lives. And so, in my opinion, I think that it's a part of, yes, Mr. So-and-so, yes, Miss, how can I help you? Please sit here. Things have been tough. You want to establish that trust and give them a sense of dignity, because that's how the relationship gets started. And then from that, you have to have a keen awareness of what their environment is like. And unless you've gone out on the street with Dr. Withers, Jason, the people that are committed to this, it's very simple to say to somebody, listen, you're going to have a wound dressing on your knee. I want you to go home. I want you to wash it 3 times a day, change your dressings, and come back to me in 3 days. But what happens if you're living under a bench and there is no water? What happens if you have no access to hygiene? There's no soap. So in my mind, this is what we try to do, is to, again, MacGyver the situation so that you're trying to create the worst scenario. You're expecting the worst scenario. You're taking care of it. I'm treating somebody in my clinics, or Jim has a patient he wants me to see, and I've just got to assume that this guy's not coming back. So I give him stitches that dissolve. I put him in boots, and etc., that he can take off, and I'm starting to consider the variables that if I never see him again, I'm going to try to optimize the situation. And then, as you see Dr. Withers doing here, in this particular circumstance, you're bringing the medicine to the population. You're not waiting for them, because in these environments, and it's complex, but they often can't get to you. So, when you look at multi-systems, what we try to do is we try to reverse the things that we can. If a person is having a tough time with their pulmonary status, you can optimize it with inhalers. You can use oxygen. You can diurese them if they're in congestive heart failure. If they can't eat or have malabsorption, you consider these issues. And it's important to give them nutrition, because as the body goes into a positive nitrogen balance is when you can actually start to see wound healing, and it's amazing. Somebody gets somebody in who's got an albumin of 1, and all of a sudden you give them tube feeds, or you give them energy bars or protein drinks, and then right before your eyes in 3 days you're starting to see pink granulation tissue, so it definitely works. And then you've got the risk factor abuse in this population, which is huge, and that's the smoking and the alcohol and the drug abuse, and that is really a difficult problem. I think that's one of the hardest things to overcome. And then, of course, the mental health issues, which many are afflicted. So this is my kind of little, in my own wound clinics that I keep around, that if you just took these 2 chucks with everything on here, you could pretty much take care of 90% of your problems. Something topical for anesthesia, a surgical blade or a curette to try to at least reduce some of the debris, sponges to absorb the wetness or the drainage. I'm a big fan of Una boots in lower extremity wounds, especially the ones that you can take off now that are pretty easy to get to. And then we use other things like honey dressings, and of course those of you on the street have seen the classic maggots in a wound. Maggots have saved more limbs probably than I have, so I can tell you that they have their role. And then again, bringing the medicine to the street. We're blessed in Pittsburgh, and perhaps much of it is Jim's initiative, but there's not really a hospital in the city that turns these people away for the most part. And I think in California it's been a little bit different. I'm kind of surprised when I go to Los Angeles and I see the environment that my daughter's working in. Cedars is the number one that comes to my mind. But you have to be able to work with clinics and medical establishments that are willing to accept these people. And because at some point they're going to need something more than you can just do out of a van on a street corner. And I think to really be successful at this, you've got to convince the populace, or you've got to convince your communities that it's really necessary to have these, and the funding has to be set aside for these people. Because if you take care of them, you're going to lessen the burden and the other drains on society that they're going to have when they get really complicated. So I think you need to be proactive. You need to get to the street and manage these problems and try to get these people in your network so you can avoid before it gets too late. So the other thing you have to understand is that wounds are dynamic. And you've got to be prepared to change course. So what you do on day 1 may be considerably different than what you do on day 5. So it's avoid the routine, all right? You've got to look, and like I tell my residents when they go on rounds, and I'll say, you look but you don't see, or you listen but you don't hear. And it's very important to be very aware of the milieu because, again, your plan is going to constantly be changing. So we get to the operating room and we've got all these technical things. We've got the ability to use hydrojets for debridement. We've got ultrasonic scalpels. We've got blood loss machines. I can sit there when I know I'm involved in a big reconstructive trauma. I've got machines that will suck the blood out of the environment and give it right back. But certainly on the street you don't have that. Small little wounds. You take something that presents like this, and all of a sudden you think that it's 3 stitches, and then you find out that half the femur is involved, and you've got to take that apart. So there's what's beneath the surface is not always readily available, so it's like the iceberg effect. And then of course it's the medical management. You shouldn't have edema like this get to a point where you have a leg that's on a guy that came into our clinic that was basically lived under a bridge and allowed just basically chronic lymphedema get to a point where it's like elephantiasis. And at this point, they can't even walk. Then they go through 5 operations, and it's a huge risk. So again, it's recognizing the issues early. So the follow-up, that's really important, and Jim will allude to that. But you can't, if you can't finish what you've gotten started, you may take a step back, and that can be quite frustrating. These were my clinics in Haiti, which I'll allude to just a little bit, because I think if you're really enthusiastic about taking care of this population and you want to make a difference, you need to get on a plane and go somewhere. I'm really jealous of Jason. I think his experience is one of the greatest I've ever really talked about. But I was in Haiti shortly after 4 weeks after the disaster and of the earthquake. And these would be my clinics. They'd find out that there was a surgical team from America, and every morning we'd get 300 people that would literally come from the entire island, and they would wait in line all night, and I can only pick 10 that I could take to the operating room, and the ethical decisions that go into who are you going to help and who you're not, and you're going to turn away 290 people, and it could be emotionally it could take its toll. But the problems that you see that you guys have no really, thank God you have no clue, is the environment of the street. The street violence is just really sensational in some of the things that I see. This was a guy this was a woman who was living in a van with her significant other, and they were on a drinking binge, and he decided that he didn't want her anymore, so he threw her out of the car and dragged her on her face for about 150 yards before she was able to break free from the car. And basically she has her skull. This is her skull exposed here, and this is basically her hemi-face that's been basically taken away. So she gets to the operating room, and there's surgical control of the wound. We beef her up, we detox her from alcohol, we put a feeding tube in her, we get it so that the granulation tissue is nice and healthy, and this is her skull. And then part of my training is microsurgery, which we have probably one of the largest microsurgical units in the country. And this is her serratus muscle, and this is her latissimus muscle, and it's hooked into small vessels in her neck. And by a composite reconstruction, we're able to now cover the skull, cover the hemiface. We sheet graft her, and then we're able to get her back to at least in a situation where she's presentable to society, and hopefully provide her an opportunity so that she's not back again. Because part of this is not, I spend 10 hours in an operating room with this woman, But it's really important that from this point we get her to another level in her life, so we can try to rehabilitate her. And I think that's the greatest gift that we can give her. Drug abuse, and this is rampant. It's certainly not just that to the street population, but this was a street individual who, through crack cocaine that he was snorting, developed a brain abscess. And in the acute phase, we, with our neurosurgeons, he got terrible brain swelling. We drained the abscess in the brain, and basically this is his calvarial defect on a model. And you can see how his skull's been crushed and removed because they had to take out the outer portion of the skull in order to let the brain swelling relieve itself. So now we're stuck with a defect, and I was involved in this early, so I was on this mission to try to make this guy whole. So this is a picture of what a brain looks like, unless you've ever been in the operating room, but the brain's kind of like cottage cheese, and it's very soft in consistency, and so we needed to find something to cover this. So we used a rectus muscle, and this is the blood vessels that we use with microsurgical techniques to cover the brain. And then we go from this coverage to a model now that fabricates this skull. And this is all donated, by the way, which is really amazing, because you know, I talk to my guys and I just tell them, I tell my reps, listen, you want me to use your Strykers and your Synthes plates and all this, and this is what you're going to do for me. And when they say no, I just say, well, there's somebody else that'll be interested, and you got to play ball with these guys. And they really know that this is important to me. And so this is a fabrication of a plastic mold that is recreating the defect, and it goes back in, so you can see the skull here. And here's him reconstructed now, so that both sides are almost identical. And again, you can take somebody like this, and by the way, he lost his eye during this as well. So I guess the take-home message is don't snort crack cocaine. But frostbite in this population, another big problem. Jim, I don't know if you remember this guy. He was this guy was in one of the abandoned houses on the north side and came to us with his feet off. Essentially, we took his plantar feet both off. I assembled one of my fellows, and we got 2 operating teams simultaneously. And so this operation took us about 15 hours, and we were able to reconstruct the soles of his feet. And here he is now suspended, but at least we gave him his feet back. So again, a tough problem in a situation in a very vulnerable population. Tissue necrosis, this is necrotizing fasciitis, or the man-eating bacteria that you read about. Starts out with a little ankle wound, then it ascends up to the knee. And again, microsurgery to put him back. Necrotizing infections, again, a poor soul here. This started out as a blemish. She lived on the street, watched this for a number of days, became really sick with terrible headaches, came into the ER with a white count of 30,000. This is the laudable pus that Hippocrates talked about, and it's this mushy, soapy water, dishwater-like fluid that comes out, and by the time you take this, you end up like this to get surgical control of this wound. And this is a young girl. She's in her 30s, and you can imagine what you think in your mind when you have to do this to somebody. And so we get the wound primarily closed, and then we use a system of expanders, no different than a flat belly in a pregnant woman over 9 months extends itself, and we recruit skin around here. And then basically we put these balloons in her skin and we blow them up slowly so that we have additional skin to use this, and we try to then at least give her her body back. And this is the part of the dignity that's a real, in my opinion, a real important aspect of the human spirit. It's more than just being injured. It's being able to look at yourself and feel good about yourself. And even if I can I'll let my fellows, I run an aesthetic surgery clinic, and I'll let my fellows, I staff them, but it's an amazing feeling to take somebody who just feels so terrible about themselves that has no means, and we can bring them back a look so that they can smile and look in the mirror, and that's very rewarding. So I'm going to close in just touching a little bit about the disaster components of what you can do in conditions that are so primitive that you just push yourself. And of course, this was the January 12th, 2010 experience. And I'd been on missions before, but I'd never been in a disaster situation. So imagine Santa Barbara being hit by an earthquake, and all of a sudden, in 10 minutes, 250,000 people are dead. Another 200,000 are wounded with no health care. And that data is greater than Hiroshima and Nagasaki combined. So you get there, and it looks absolutely like the apocalypse. And so from this, I can tell you that these 8 people will be endeared to me for the rest of my life. So the LEAP organization was a life enhancement association for people, and it was sponsored out of a plastic surgery group in Dallas. The American Society of Plastic Surgery took them as their basically body to recruit. So I threw my hat in the ring 1 hour after the earthquake, and they said, we're not going to need you now because the whole world ascended to Haiti. And within 24 hours, they had teams from everywhere on the planet trying to help these people. But then they all leave, and you're stuck with all these external fixators and all these bones that are malaligned and gangrene and all the other things. And then you say, okay, now what are you going to do? So we were very busy and very needed at that time. The destruction was nothing like I've ever seen. And there was people living in these complexes that were ready to come down, business as usual. They're selling sodas and fruit right out of their home, and they're living in this hole because they have nowhere else to go, or that in a tent city with a dirt floor. The filth just rampant, cholera, tuberculosis, things that you just, malaria. And so really the people that went with me, just amazing spirit. But this was our guarded entrance. Every morning we would go through these hospital gates because there was such a demand. I showed you the lines before. That was the lines outside to get in. And this was the line that I saw every morning. And these people, somebody knew somebody who knew somebody. And then I got tired of the politics, and I would go outside in the lines myself. And I'd say, I don't care who got in here. I want to see everybody that's on this campus because I'm going to make the ultimate decision. And we would pull people out of line and say, we can help you, let's go. We had no blood work. We didn't know what their sugars were. We basically had a glucometer and a blood pressure cuff. And we just said, if your sugar was less than 400, we'll do you. And you have no history, and it really is it's quite a challenge. This is one particular example, 12-year-old child stuck in a rubble for 18 hours. Her hip bone was exposed, and she had what we call osteomyelitis, or a bone infection of her hip. Her mother was killed in the onslaught. This was a right leg wound that just by serendipity had not healed. You can imagine this is what this must have looked like 2 months out already. And then you can see the hip wound. This is her whole entire hip is exposed here. So we're operating with Home Depot lanterns on our head with 2 AA batteries and instruments that basically look like they came out of a play school kit. And we're elevating on blood supplies that are specific. This is a lateral circumflex femoral artery. It means nothing to you guys, but you'll know it one day. And we're raising her entire thigh on this to try to cover this area here, which is her hip. And so the point of this slide is we've got the wound covered. This is an area that we grafted for the other side of the wound. But the amazing thing that I found, which is something that really I think needs to be duplicated in the States, nursing care is stressed to the limit in every hospital in the country now. Everybody's trying to cut back on costs, and nurses are overwhelmed. So in Haiti, you gave the family the chore of taking care of patients because there were no nurses. And you said, listen, this was the father, and I told him, I want this wound scrubbed 4 times a day. I want the bandages changed, and it looked like it came out of pristine. It looked like it came out of a manual. And I was so amazed at the closeness of family taking care of patients that it really, a light bulb went off. This particular situation, you see this woman here, she was a school teacher. So she was on the first floor of a 4-story building that came down upon her. They had to cut her arm off to extricate her while she was awake because they couldn't get her out from the rubble as well. She lost her Achilles tendon, and she had a very large head wound. And this was the sophistication of the transport. Remember, this is how we did it in the Civil War. So I talked to you about dignity. These are people that were very uncomfortable for religious reasons about taking off their clothes, and particularly in front of men that were unknown to them. So we would put them to sleep fully clothed. Then we would take their clothes off, do the operation, and out of respect to them, redress them before they woke up. And so, again, it's the dignity component that I'm talking about, and it's the trust that they start to have for you. This was the skull, and again, this is an infected bone plate. So that's taken off, And we basically take the scalp apart in multiple quadrants, and we open up the skull, and then we move it around so that we can get a closed wound. And she came back to the States in Dallas about a year ago, and I flew to Dallas to be with her, and it was really an amazing experience. You got to do what you got to do. So the last time I saw a C-section was in 1981, and so we were in my operating room, and this was the birthing rooms. And you would go into the birthing rooms, and they would be dropping children like flies coming off the ceiling. You'd turn around, there'd be another kid, and then somebody would be eating a sandwich, and oh, this one's coming out, and then put it down, and then catch it, and then another one would come in. And so all of a sudden they said, we had an anesthesiologist, it was a pain specialist. They said, we have a child that's having problems right now. Do you think we can use your OR? Can you do a spinal for us? He said, absolutely. So they said, well, we don't have a surgeon to do the C-section. So I said, well, we don't either. And they pointed to me and they said, listen, if you don't do this kid's got no chance. So I just basically started cutting till I saw a head. And at that point, it pops out. And so I tell my surgical team, this is the child. His APGARs were like 30 and 30. He had basically, he was listless for about 4 minutes. And I turn around and I said to one of our surgical nurses, I said, is that baby dead? And I tell the story now, I get emotional about it, and I'm saying, you got to do something with this kid. So the midwife was Vietnamese, and she had no clue. She didn't speak English. She was doing nothing to the child. So thank God, it was like a message from God. But one of our surgical nurses was an ICU pediatric nurse from Dallas. And amazingly, she just took over. She was able to cannulate the kid's bronchi, suck this thick inspissated meconium out of his lungs, and really got him to start crying. The whole OR is crying, everybody, including me. I'm going, this is like unbelievable. I got this uterus bleeding all over the place, and I'm looking at this kid like this going, and all of a sudden said, you better stop the bleeding. So at that point, it just gives you an idea how amazing this experience could be. So, I've done, I've treated 60,000 people since I started my practice, and this 8 days was the greatest 8 days of my life. So it just gives you an idea how special this is. It's the feeling that when Jim goes to bed at night, he's made a difference in this world, and there's no special or greater feeling. You can't put a price tag on that. So that was our miracle baby. That I have a 8x10 of this picture, and it's very, very meaningful to me. So, in principle, have a plan B. Be prepared to change course. We had a young student today who came and talked to us, and he says to me, I want to know everything. I want to be like Jason. I want to be able to grow up and take care of everything in the world. And I told him, you know what? I know a lot about nothing. Because when you get so super specialized, your life goes in one direction, and there's so much to know. And you could start out on your course, and all of you here may want to be doctors, and somebody wants to deliver babies, and next thing you know, you're a psychiatrist. But that's okay, because at the end of the day, as Jason said so eloquently, if you are having fun, it doesn't matter what you're doing. And I would do this for absolutely nothing if I was capable of doing that. So, be prepared, think, act. And then the rewards are amazing. There's nothing greater than the gift of giving. There's no greater reward. When you go to bed at night, you just figure out what you've just done. If you can change one life, if Jason, Jim, and myself can make one person in this room a contributor to society at a level that separates yourself from everybody else, this is a very important hour for you guys. The ultimate give back. And really, at the end of the day, you're making a difference. Thank you very much.